So good evening and welcome all of you for this today's NOEL session, the seventh session in the series. And today we are going to cover the high frequency ventilation, few of the principles, how it works, and its bedside application and disease specific, how to optimize its use. I won't go into detail of the evidences, which we can discuss in some other seminars, but the evidences won't be there, only the physiologically why it works well in comparison to conventional ventilation and what are the specific uses. In absence of a volunteer on the bedside presentation of HFO babies, which as per the sequence, the respiratory module, it was the last session for HFO. In absence of this, just this is will be a seminar and I will discuss 40 minutes to 45 minutes about the HFO principles and its use. And during the session or end of the session, you all are free to ask any of the questions. So we'll try to take questions and answer. I'm alone here today as a topic, the presenter, and I will moderate the session afterwards for the question answer. So thanking you all for joining the session. Almost 75 students join now. Let's start the session. In the meantime, any queries comes to your mind, you put questions in the question answer session. So the end of the session, because I'm presenting presentation time, I'm not able to see, but at the end of the session, I will try to answer all your queries. So here, let's see the high frequency ventilation, how it starts initially. Sorry for my voice today, you have to bear it with it. And that's I will try to complete within as briefly as possible. So high frequency ventilation, how it started, it started by taking or inspired by the principles of some of the nature's high frequency simulators. You see, these are the examples, typical examples, when they go for lower tidal volume but higher frequency, the managed oxygenation. These are the few of the examples in nature exist in contrast to the bigger and bigger animals like elephant and whale. These small animals with the higher frequency, they manage the oxygenation and ventilation well. With those simulation nature from nature, the scientist got the ideas how the high frequency may work for the babies with such a suboptimal, subanatomical ventilation, but we can achieve our oxygenation and ventilation. The principle started. So coming to the HFO as such, we will understand in this presentation what is HFO, how it is different from the conventional ventilation, and specific indications. What are the specific use of HFO when little advantage in comparison to the conventional ventilation? If we decided to start the HFO, majority we understand HFO never is a primary intensive ventilation. In all the uses in preterm population or specific in diaphragmatic hernia or any pulmonary hypertension or air leak conditions, usually it's a rescue ventilation. But if we decided to start to rescue the baby when the baby is not improving with conventional ventilation, how to initiate? And in different disease, how to use it optimally? And if you're using HFO, the success lies in the monitoring. Unless we carefully present bedside and monitoring the ventilator parameters and the vital parameters of the baby, probably we won't get result optimally. The key to success of HFO is constant monitoring, vigilant monitoring, and responding to changes, physiological and other parameters change in the baby during the ventilation. That's the key, probably holds key to the success. With this, we will see how the HFO is comparable to the CMV. The HFO, in a simple term, it is a CPAP or a mean airway pressure or a PWP with a wiggle factor. That's a continuous distending pressure which distends the airway, that recruits the airway, but the wiggle factor advantage beyond the CPAP, it's a wiggle factor added to that. But beyond, only is it only giving CPAP or something else? Some characteristics are a little different in comparison to conventional ventilation. So those things we will see that few of the things are different here. If you will see the parameters, you will see the rates also. If you see the rates, wise it is a supraphysiological rate. Supraphysiological means rate, normally the physiological rate is 40 to 60 in a newborn, depending on the gestation age. But if the supraphysiological, any rate more than 60, we say it is supraphysiological. This specifically, this high frequency ventilation usually operates at 300 rate to 900 rates, normally with those higher rates. So it is physiological, supraphysiological rate. But any ventilator, if we can increase the rate, do we think that it is going to be effective? It is going to be effective as a high frequency ventilation? It's not so. Other two basic characteristics should be added to the supraphysiological rate. Those are, the ventilation should happen in a smaller tidal volume. If a like conventional ventilation 4 to 6, 7 per kg we are going to ventilate in HFO, it probably won't save the lungs, it injure more. So with the good recruitment of the CPAP, with the wiggle factor, if you are using the ventilation tidal volume, which is 1 to 2 ml per kg, which is the close to the dead space, subanatomical, the subphysiological, subanatomical tidal volume we are ventilating, that's probably the achieved ventilation, high frequency ventilation. Along with that, we have to remember the biggest advantage of high frequency ventilation in comparison to conventional ventilation. Conventional ventilation, there is a sink in the oxygenation and ventilation. When we are trying to achieve oxygenation, probably we will wash out the carbon dioxide by hyperventilating. In achieving, we want to hyperventilate. Sometimes we want to ventilate the lungs with higher rate, higher tidal volume. Probably we will injure the lungs and indirectly will increase the volume of the lungs, and more oxygenation will get also during the higher ventilation settings. So they work in sync. But the greatest advantage of HFO, we can decouple. If we need to oxygenate, we'll target our parameters such a way that we can oxygenate the lungs better. If our aim is a hypercarbia condition, we want to the carbon dioxide was out, we can do it differently. That's probably one of the greatest advantage. Decoupling of oxygenation and ventilation happens in HFO. These are the basic characteristics. Coming to the physiological advantage, CPAP, we know the CPAP and the PWP, which recruits the lungs to the FRC. So how the HFO does the best work, I will show in this video. You can watch it here. This is just the lungs with CPAP. You can see the spontaneously breathing, the lab animal on the under microscope. The lungs, you can see the spontaneous breath, but a good recruitment is there. Coming to the next one, you can see here the CMB without a PWP, without a recruitment, how the shear stress, the strain in the lungs happens. Each time it expands and it's going to collapse. With that, the injuries are the highest, this type of ventilation. But by putting this conventional ventilation with a little bit of PWP, which recruits the lungs, the recruit to a volume, little higher volume, and then from there the expansion starts. And the collapse never comes down to zero, comes to a residual volume. How the ventilation happens, you can see it here. So little better in comparison to zero PWP or less PWP when we are not recruiting the lungs. But still, the expansion and collapse happens here. But imagine, like the CPAP, the way the spontaneously breathing baby with CPAP, which is should be our dream during positive pressure ventilation. But many times we have to ventilate. With one ventilation, imagine HFO, you can see both the videos you can see here. The CPAP video, which is spontaneously breathing without much collapse, similarly happens in the HFO with the wiggle factor. Without collapsing much expansion, the ventilation happens. So you can imagine now giving CPAP or giving CPAP with the wiggle HFO might be beneficial in comparison to a conventional ventilation when the pulmonary stress and strain happens more. To explain it better, I'm giving you an example here. You can see whenever we are ventilating the lungs, we recruit the lungs alveoli to extend. From there, each time with the PIP, positive inspiration pressure, during inspiration, the lungs expands more. Again, during expiration, comes to a residual volume. You see the initial first example, what happens here? The PWP is 0. The full volume we are recruiting, each time it collapses. The next second image, little better, when this positive and expiratory pressure given here. So to recruit up to this upper limit, green zone, beyond that expansion, the expiration time, the collapse happens. With the progressively, we can see with higher PWP, what happens? There is expansion of the lungs. The highest volume comes to constant. In all the 4 examples, the volume upper limit is constant, but you can see the change in the last one happens to a smaller extent in comparison to the first one. So with the increasing PWP, what happens here? The larger static strain will stretch the lungs, static strain. the dynamic component is less. So though the expansion happens to a volume, if a recruitment happens by giving the PWP or CPAP with mean air pressure in the ventilation, HFO ventilation, and the only minimal movement of the lungs happens each breath, probably the injuries are lesser and lesser. That's the basic principle of the HFO. When it recruits to a great extent, from beyond that lungs wiggle up to a upper limit, it wiggles and generates the tidal volume. A smaller tidal volume can help the lungs to ventilate and oxygenate. A similar principle, another example here. During the conventional ventilation, you can see each time the expansion and completely the collapse of the lungs with a variable of tidal volume. But in HFO, with a smaller window and smaller range, we ventilate, so gets the advantage. And after the recruitment happens in HFO, this graph give us the example, or they give us the example of when we are using HFO, we recruit the lungs. That's possible with the conventional ventilation also after the recruitment of the lungs. But when we are seeing a mean air pressure, when we talk about HFO ventilates in the expiratory limb, means after the recruitment, you can see here both the examples when there is a under recruitment process in the similar mean air pressure, you can get the tidal volume here lower, but after complete recruitment of the lungs, use the tidal volume, you can get a higher tidal volume with the similar pressure. So the key of the HFO is recruitment. If recruitment you have done once, with a lower pressure, you can get a better tidal volume. So less injuries are the injuries are less in the HFO once the recruitment starts. So similarly, you can see the similar graphical example here in the lung experiment. Initially, we can see here from when the map or the PWP, when the 0, we can see the how progressively when we are increasing here, the expansion and recruitment happens. But when once recruitment over, the recruitment process over, we are decreasing the further map of the PWP. Still the each corresponding 4 PWP here, 10, 10. You can see once the recruitment process is completed, with the lesser map also, we are getting good recruitment to the lungs in the lower panel. And so that recruitment is better, that volume is better, the oxygenation is better, even though we are using lesser pressure in the lower panel once the recruitment process is over. So the key, the HFO, not the settings such a way to choose so that recruit the lungs well. So by X-ray, you can see a 6 to 8 rib spaces in the X-ray above the diaphragm. After achieving that, we can live with less injury, less tidal volume, we can ventilate better. That's the key principle of HFO. And coming to how the different, this example, all the 4 points I have already spoke here. I'll move to how the HFO, the gas exchange happens, how it is different from the conventional ventilator. This picture is very familiar, very common picture whenever we are speaking about HFO. When we speak about HFO, we remember that there are 5 important mechanisms by which the conventional ventilation, what it happens, the inspiration time, a convective bulk of air goes into the lungs each time. So that causes the injury. But in the HFO, we believe there are different major mechanisms are there, whether without less injury, without forcibly when we are the conduction happens, the air conduction happens from the proximal bronchus to the alveoli. Here, what happens with different newer terminology, I will use it here. A few of the things may be new for you. You have to read it with the standard textbook. Some of the turbulent mixing happens. Nothing is pushed here. The convention current or the diffusion of the gas happens. The basic principle of HFO gas exchange. How the oxygen goes due to the turbulent mechanism, the trachea and the proximal bronchioli gets oxygenation initially with the turbulent mechanism. And during some of the proximal alveoli, which are close to the initial, the major bronchus, gets the gas, the oxygenation, they get by the direct ventilation by the turbulent mechanism. Beyond that, you can see the upper and middle class of bronchioles and the bronchus, they get by 3 different mechanisms: the asymmetrical flow velocity and the Taylor dispersion. I will come to that Taylor dispersion later. And the radial mixing happens in Taylor dispersion. And to the last diffusion happens, the alveolar level, the diffusion of the gas happens, the oxygen goes in and the carbon dioxide comes out. This all the process happens through the diffusion principle, but how they work in different generation of bronchus, few of the mechanisms will understand better. If we are putting a gas flow, this laminar flow, you can see it here. But when in the HFO, the frequency of the gas pushed into the tubular structure of it is not exactly tubular structure, the branching pattern of the bronchus and bronchioles. When this type of asymmetrical flow generates, you can see the area of diffusion instead of a horizontal line here, the area of diffusion is more. So it reaches to the more area during the inspiration without much pressure. And Taylor dispersion, the example of how it comes, you see the horizontal flow. When a bulk flow of gas goes, the molecules, level of molecules, how many levels are there? It's 5 molecules, for example, it disperses into the alveoli and bronchioles. But with a Taylor dispersion, when there is this is with the asymmetrical flow and the apical flow happens, the Taylor dispersion, molecular diffusion happens, you can see the area in the same flow, it supplies more larger areas of the bronchioles and the alveoli. With these major two mechanisms, probably the gas exchange without much force, it exchanges all the alveoli. And how the carbon dioxide comes out, we believe the central oxygen flow, the red flow, the oxygen flow goes inside, and the peripherally, radially, the carbon dioxide comes out, the expiration. In comparison to the conventional ventilation, the expiration happens passively. But here, in the HFO, active expiration happens, so the carbon dioxide comes out peripherally simultaneously whenever the inspiratory flow pushing some of the oxygen, the carbon dioxide parallelly that comes out is an expiratory movement. To understand that, we can see this picture. This parallelly happens. This is a new principle, new theories in comparison to the previous theory. This is a Lagrangian drift. Whenever there is a fluid movement happens, this newer concept they are applying, they're saying inspiration over expiration comes, it is not like in conventional ventilation. The inspiration and expiration happens parallelly, but you can see during the inspiration, in the middle picture, the inspiration, the oxygen the centrally diffuses into the lungs. During expiration, the same oxygen peripheral is still going with the dominant force. The expiration time, the dominant blue is central, you can see the carbon dioxide comes out. So parallel it happens. So both function happens simultaneously when you use HFO, but in different layer, the proximal layer, the bronchus, the bronchial generation, alveoli, different mechanism acts simultaneously. And coming to now the machines, we use different machines now. India, all the varieties of machines are available in HFO, but they are not equal in the efficiency and equal in the few of the basic parameters. So whenever we are using a machine, we should go to the manual, we should understand how it works, then probably the best way we can use it. You can see different principles are there. So I won't go to different principles of HFO, how it works. But in general, if I'll say the baby log, 8,000 baby log, if you're using for HFO, it is not a true HFO, it's a flow interrupter. It's a conventional ventilation with the flow interruption. So in a bigger baby, it may not be effectively use the HFO. So a small baby, 1 to 1.5 kilo, the company claims up to 2 kilo, we can use HFO. But if you're a bigger baby, more than 1.5 kilo, up to 4 kilo in a newborn, or a bigger infant, you want to use probably more powerful machine like VN500, SLE 5000, SLE 6000, or the most powerful machine, HFO machine like Sensormedics, you can use to get the best result. But in dragger baby log, if you're using for HFO, smaller babies, it can work, but as it's not a powerful HFO machine, it's a flow interrupter, sometimes it may not be effective. So you remember different mechanism, but the efficiency wise, we have seen in the neonatal population, these dragger companies, VN500 or 600, this Ecutronics, the 5N HFO or SLE, they work similarly. And the previous generation, the Sensormedics is a dedicated HFO. So if once you need HFO from conventional, you have to take to HFO machine. When HFO you want to wean or you want to take to a conventional ventilator, you have to use another machine, another ventilator machine. But current generation, Ecutronics, VN500, Sophie, SLE, this is all what they do. You want to use HFO, you can use escalate and rescue HFO. Whenever the baby improves, you want to come down to conventional ventilator, you can come to the conventional ventilator, the same machine by changing the setup. So that's the advantage of newer machines. And the parameters, when it comes to parameters, you remember the parameters of conventional ventilator, maybe PIP, positive inspiratory pressure, PW positive expiratory pressure. There are TI inspiratory time, TE expiratory time, the rate, and other sometimes we have to address the flow. So multiple factors we have to set. But here in HFO, the parameters are relatively simple because FiO2 is constant, oxygen is constant with the blender across all the respiratory support machine. If HFNC, CPAP, NIV, conventional ventilator, HFO, everywhere the FiO2 is constant, which helps in oxygenation. Beyond that, you should remember the three parameters. The mean airway pressure, which is a combination of factor in conventional ventilation when we are seeing PIP, positive inspiratory pressure, and PWP, both contribute to the mean airway pressure. Here directly, we can choose a mean airway pressure in the ventilator setting, which helps in the oxygenation. So the FiO2 and mean airway pressure, this both helps in oxygenation. And the frequency, the rate, by adjusting the TI and TE, many times we adjust the rate in conventional ventilation. Here the rate of the frequency, so frequency of the rate, how it works in HFO. If you are choosing frequency 3, remember 3 multiplied by 60 is the rate, that's 180. If you're choosing frequency 5, the 5 multiplied by 60, 300 is the rate. But directly as Hodge, you have to set in the ventilator, HFO ventilator, which directly the set the rate, the frequency. And amplitude is the wiggle factor. We'll see in video how the wiggle works. The wiggle factor is different in comparison to conventional ventilator. Conventional ventilator, which each breaths, the chest expands, and each expression again just comes to a basic level. But here in amplitude, it is the factor, wiggle factor. There's a constant, the chest wobbles, which with probably lesser movements, it helps with the ventilation and dispersion of the gas into the lungs. So these are the factor, the amplitude factor or the ventilation factor, the frequency, the rate factor, or the mean airway pressure. These are the three direct things we can put in. We can directly choose in the HFO ventilator. So to explain it better, you can see each cycle, just for the frequency what we are setting, each cycle it changes. This is one cycle inspirated and expiration. This is another cycle. So the frequency depending on frequency. Usually the common ventilators, they go to as low as 5 frequency, as high as 15 frequency. So 15 frequency means 15 multiplied by 60, 900. 5 frequency lowest 5 multiplied by 60 is a 300 frequency, 300 rate. This operates, the HFO operates in the range. But some of the ventilators, they have facilities as low as 3 frequency, 3, which is very, very low, unusual. So rarely anybody uses that. And some of the ventilators, they will have up to 20 frequency, 20 multiplied by 60. You can say that is 1200 rates. So some of the ventilators, very, very small babies, 500 grammars, 600 grammars, sometimes 15 frequency also. There's a higher frequency for the baby, lower frequency for the baby. Sometimes we have to increase it to 18 and 20. Few of the ventilator machines have that facilitation. So that's the way the frequency works. In delta P, that's around the mark. There's a mean airway pressure, which we are setting. Around the mark, the amplitude factor movements happens. The amplitude with the wiggle happens. It goes in, comes the inspiration and expiration phase, it happens. And how the inspiration expression different with different I time. Normally, you remember the frequency, we don't change much in the HFA. When the frequency we are setting across the disease process, HMD, a meconium aspiration, a air leak condition, a pulmonary interstitial emphysema. Once we know the disease, we will later learn how we set the frequency. We keep it constant throughout the disease process. What we change? Usually we change the amplitude to adjust the ventilation. Mean airway pressure and FiO2 we adjust for the oxygenation. But frequency we keep constantly. Like that, another parameter, the TI or TE. So I-E ratio. Majority of old HFO ventilators, the standard recommendation was I ratio 1:2 you keep. The current generation of HFO ventilator, they are suggesting I ratio 1:1, we can keep it 50%. So you see, if I ratio is 1:1, the inspiration expression looks uniform. The amplitude's uniform, it looks like the previous circle uniform. But if the I is 1:2, you can see the inspiration looking taller than the expiration. So depending on the I, the amplitude, waves a little bit different graphical way, but we have to remember that newer generations, they are recommending now the TI is 1:1. So it looks uniform, the amplitude looks uniform. In the mean airway pressure, you can understand a constant mean airway pressure will keep depending on the disease process. We'll understand how to choose. And the When we are keeping a delta P of 15, 20, you can remember I ratio if 1 is to 1, it moves positively half of that 7.5, negatively half minus 7.5. The combination is 15. So it along the axis of map, it moves up and down when the amplitude we adjust depending on our need. So we'll understand next few slides how to choose map, mean error pressure. The oxygen FI2 I'm not describing here because FI2 always depends on the oxidation target 90 to 95%. We want to achieve a saturation 90 to 95%, irrespective of any disease process. To get that, the blender, we can adjust any point of time from 21 to 100%. So FI2 is a direct dependent on the saturation or the PO2 target when we are doing 60% around PO2 we are targeting. Rest all the other parameters, we will learn subsequent slides, how to choose MAP, how to choose delta P amplitude, and how to choose our frequency. So depending when we are speaking here, we'll see how to choose the mean error pressure first. So mean error pressure depends on the disease process. Mainly the mean error pressure is the pressure which transmitted to the lungs, and it from the atelectatic lungs, by increasing the mean error pressure, it recruits the lungs more and more. Except in the few conditions, the MAP should not be increased for the recruitment. But recruitable lungs, like a typical example, I will give a preterm RDS, a congenital pneumonia with a lot of atelectasis, with a heterogeneous mechanism aspiration, with atelectasis hyperinflation. These are the conditions the lungs is recruitable as per the need. But some of the conditions, non-recruitable lungs or recruitment not needed, like pulmonary hyperplasia, like diaphragmatic hernia, like anatomical malformations of the lungs, or already existing early conditions. When majority we don't need, or a cardiac disease where lungs is not primarily diseased. Those are the conditions probably recruitment we don't require. Other recruitable lung disease like preterm RDS prototype, we go on increasing the mean error pressure. The oxygenation will improve by recruiting more and more alveolar units. That's the basic principle. So how much to choose? Depending on the lungs condition. You can see the first, this X-ray, how the X-ray looking hazy, completely white out. By recruiting the lungs, we may get 6 to 8 rib spaces. When we are getting adequate recruitment happens, by X-ray we can monitor. But if we go on increasing the MAP inadvertently, we will get more and more rib spaces and the lungs may be hyperinflated. So we should be careful. We should recruit without any hyperinflation. So for that reason, when we are choosing a MAP, as per the disease process, mean error pressure, within half an hour to 1 hour, do an X-ray to know the recruitment process. So HFO, empirically, you cannot leave it in a small baby. So if you're setting HFO, setting mean error pressure, within half an hour to 1 hour, check with X-ray. So if hazy lungs, within half an hour to 1 hour, if recruitment happens, we are getting 6 to 8 rib spaces above the diaphragm when we're counting posterior ribs. Or we are getting 9th rib above the diaphragm. Probably that's our target should be. And when we are mean error pressure, when we are choosing a mean error pressure, to deliver the mean error pressure, we should remember one is the disease process for which you will choose and monitor by X-ray. And this I'm not going in detail, but to mean error pressure rightly to deliver, the circuit which you are using should be the recommended circuit. You will still see if a circuit compliance is poor and the ventilator circuit expands during the pressure setting, it won't deliver the right mean error pressure. So remember, depending on which ventilator you are using, choose the recommended ventilator circuit for the right MAP to deliver. Accordingly, you choose the right ET tube size. If a smaller diameter ET tube size you are choosing, your amplitude and mean error pressure won't deliver the lungs properly. So as per standard recommendation, a little bit of larger size, one size larger, 2.5, 3. If the recommendation, choose 3. If the recommendation is 3 or 3.5 ET tube, you can choose 3.5. This is on-cuff tube I'm speaking. Choose little higher size of tube. Your mean error pressure and amplitude delivered will be better. In narrow tube, when the secretions can block the tube, the amplitude and mean error pressure may not deliver the lungs properly. So for that reason, the right tube and the right circuit of the ventilation is key to deliver the mean error pressure. So now after that, how to set, you see, we are speaking from beginning, the mean error pressure when we are choosing, in majority time, the clinical situation is we are using a conventional ventilator. The baby is not improving, not oxygenating well even after using 100% oxygen or 80% FI2, 90% FI2. We are not getting our oxygenation. We want to the lungs to recruit more. A preterm RDS, we have used already the pressure 20, 22 PIP. The mean air pressure sitting at 10. The oxygen is still requiring higher. We think that this is the recruitable lungs. We can recruit a little better. The rescue condition, we can shift to HFO. Or in PPHN also, we can shift to HFO. In air leak condition, already the lungs, you drained by ICD and you want to a safe ventilation. Sometimes we do the HFO ventilation. In those conditions, whenever recruitment required, I will suggest you see before changing from conventional ventilation to HFO ventilator, see how much mean air pressure you are using in the conventional ventilator. If you want to a high volume strategy, means you want to recruit the lungs more, preterm RDS, congenital pneumonia with atelectasis, then those conditions probably use 2 cm higher mean air pressure than the mean air pressure in the conventional ventilator. Conventional ventilator may be 10 MAP or 11 MAP or 12 MAP already generating. You can choose more than 2. 10, when there it is 12. 11 MAP, it is there conventional ventilation, choose 13. So you can choose. But you don't want to go for high volume strategy. You want to low volume strategy or optimum volume strategy like CDH, air leaks. So use how much mean air pressure used in the conventional ventilation, same mean air pressure directly you can choose. And after choosing the mean air pressure, see, is there improvement in oxygenation FI2? If oxygenation started improving, you are probably in the right mean air pressure. If not, you have to increase 1 or 2 factors. Within half an hour to 1 hour, you have to do a chest X-ray. See the 6 to 8 rib spaces. So 9 rib is visible above the diaphragm. That's you are achieving. Probably the recruitment is over. If not done within half an hour to 1 hour, you chosen already empirically 12 or 13 mark. You're not able to recruit the lungs. You can go one by one, 1 cm at a time, and again recruit and check later. Is there improvement of oxygenation? The point where the improvement of oxygenation from 100% FI to need, it is decreasing further and the saturation is maintaining. That's the point probably. That's the point. What you can do, you can decrease the mean air pressure a little bit lesser than the mean air pressure where we achieve the improvement in oxygenation. You can decrease a little bit, keep there constantly with further monitoring of X-ray after a few hours. So this is the way you can choose empirically one value, see that is the improvement. If not improving, correlate with X-ray, and at a time you go one value higher. Be careful when you are MAP, you're increasing like that. You are now worried about FI to need, PCO2 is there, a hedgy lungs, I am recruiting, but target should be this middle figure where the recruitment is optimum. But if you will use inordinately higher mean air pressure, as I told, there will be further tachycardia, hypotension possible because of the decreased venous return into the cardiac chamber by increasing positive pressure in the intrathoracic chamber. So a lot of pressure increase sometimes cause harm in the form of decreased preload, hypertension. And in the preterm population, some of the preterm babies, if you use higher MAP, it can induce air leak or IVH. So be careful when you're using MAP. Empirical mean air pressure you can use to get oxygenation, but check within half an hour to 1 hour. That's my message. And further clinically you monitor so that you will get the right mean air pressure. Whenever there is a little de-recruitment, lungs looking hedgy, you can increase the mean air pressure 1 or 2 factor. When you are doing suction and there is a de-recruitment transiently, transient to recruit the lungs, you can use 1 MAP higher than existing mean air pressure. And when there is improvement starts, you started with a 100% FI2. Now, slowly there is improvement happens. It comes down to 60% FI2. You review, probably improvement of oxygenation below 60% FI2. You review, so the previous MAP, how much have you used? Decrease MAP 1 cm or 2 cm. Then further wait. If there is no further deterioration, FI2 further once decreased, you can go with the decreased mean air pressure. So when you are getting a mean air pressure, you are started oxygenation improvement starts, you go on decreasing the FI2 till it reaches 60%, then you decrease your mean air pressure. That's the way normally oxidation we handle. So how to handle the carbon dioxide removal? Carbon dioxide removal again by influenced by 2 factors here. One is delta P, the amplitude, other is the frequency. So directly we can choose both the factor. Remember, in conventional ventilation, the minute ventilation dependent on rate and the tidal volume. So tidal volume, to get the minute ventilation better, we have to increase tidal volume, which directly proportionate, but with increasing tidal volume, it increases the injury also more. So now our target is with a lower tidal volume, the 1 to 2 ml per kg, we want to ventilate in the HFO. So here also the minute ventilation influenced by rate and the volume square here. So mild change in the tidal volume in the HFO, there is a larger impact will be to the minute ventilation. So this delta P, which controls the ventilation, but frequency directly alter the tidal volume to a greater extent. So remember, when you are choosing a frequency depending on the disease, don't change it much during your ventilation. With a minor fluctuation in the ABG, you don't change the frequency. Frequency usually pathology specific or disease specific. Try to keep constant. So what you can see if you are try to keep it constant. So what you can get, the alterations won't be much. Otherwise, large fluctuation of carbon dioxide possible with a little bit of decreasing in the frequency. The tidal volume suddenly increases, the carbon dioxide washout happens. You increase frequency, there will sudden decrease in tidal volume, there is retention of carbon dioxide happens. So that's, try to keep it constant, though we may have to change depending on the clinical scenario. So my point here, frequency influences greatly to the tidal volume. In the minute ventilation, is directly proportional to the tidal volume square here. So a huge variation happens minute ventilation. So careful about when you're choosing frequency. But frequency delta P both influences your minute ventilation, which again influences your carbon dioxide removal. So here one thing you have to remember again, the rate, this rate, two rates when we are speaking, the rate 30, 40, 50 when you conventional ventilation, we are going increasing, directly changes, directly proportional minute ventilation to the rate. So you increase the rate, minute ventilation increases. But in HFO, in contrast to conventional ventilation, what happens? You change your frequency from lower to higher, your tidal volume decreases. So indirectly minute ventilation decreases. That's the contrast you have to remember and you have to practice in your bedside. So frequency increases means what happens? Tidal volume decreases. So tidal volume decreases means minute ventilation decreases, but which is not so in the conventional ventilation. That's one difference point you have to remember when you are touching the frequency now in the high frequency ventilator. Here some of the animation I have borrowed from Dr. Sachin Sahab. So he has prepared this animation. I borrowed and I will just throw this animation, a video. I will try to explain you when you change amplitude, you change frequency, how grossly both the things influence the tidal volume, how they differently influence the tidal volume. This animation will now demonstrate. You see here, amplitude we are going to change in this video. So first amplitude, remember there's a 15, the frequency 15. Frequency, highest frequency in a small baby we started. The mean airway pressure maybe 10 or maybe 8, maybe 9 in a preterm babies we can choose. The amplitude we have chosen 15. So the gas flow goes towards the lungs, from the tube to the lungs. But if I'm changing keeping the frequency same 15, then all the remains same. I will change the amplitude to 30. You can see how the change happens. There is definitely increase in VT. You can see it here. The initial VT was in the red arrow. In the blue arrow, you can see here, the bigger volume, definitely, it increased. The frequency remained constant throughout, frequency 15 and 15. Amplitude changed from 15 to 30. There is a change in the tidal volume. So the amplitude, increasing amplitude, changes the tidal volume. They are directly proportional. They are directly proportional. Now we'll go to next example. Changing the frequency. Here you can see it here. Frequency 15. You can see how the gas flows there, how it generates the tidal volume. That's the tidal volume level in the frequency 15. We change to frequency 8. So what do we learn? Whenever we're decreasing the frequency, it increases the tidal volume. So you can see it here, the tidal volume level which increase in the amplitude time. With increasing amplitude, it increased, but a small change. But in frequency, when we decrease frequency, which remaining the amplitude is remain same, decreasing frequency increases in a huge amount. So that's the way the larger amount of tidal volume increase happens. So remember, so this is again a graphical presentation. You can see here with the frequency here in this column, the frequency from 5 hertz to 20 hertz. You can see here the amplitude, how it happens from 10% to 100%. Different ventilator, there is a either you can choose 10, 15, 20, or the percentage wise you can choose the amplitude and how the tidal volume changes. So you're keeping a constant, but to make it simple, 100% amplitude we are keeping it here. You can see here with different frequency, the highest tidal volume happens with the 5 frequency and lowest tidal volume happens with the 20 frequency. So higher the frequency, lower the tidal volume. That's the way the variation happens. So remember it. That's constantly happens. And another concept now I am going to explain here. We remembered from the beginning only, there is a coupling or the sync happens in the conventional ventilator. The ventilation and oxygenation, they are interrelated. The ventilation influenced in conventional ventilation by rate and tidal volume. Tidal volume is influenced by positive inspiratory pressure and minus positive and expiratory pressure. That's the delta P. And the rate influences ventilation. And the P for mean air pressure, I time, and FiO2 influence the oxygenation in conventional ventilation. In HFO, what happens? The frequency, amplitude, I time influence ventilation, and mean air pressure and oxygenation influence the oxygenation. That's the way we learn. So what we learn in HFO, conventional ventilation, the rate can influence the oxygenation. The PIP, PWP also can influence oxygenation, but in HFO, they are decoupled. They are not interrelated. So you can see progressively when we are increasing the mean air pressure 5, 10, and 15, progressively increasing. You can see it here from 5, 10, and 15. The PCO2, because mean air pressure is increasing, the ventilation unaffected, the PCO2 remains horizontal. But PO2, with the progressive increase in the map, the oxygenation improves in a huge extent. So there is decoupling happens. By changing the mean air pressure, I am improving the oxygenation without affecting the PaCO2, which won't happen in the conventional ventilation. If I'm changing PIP, it increases the mean air pressure, but equally increases the tidal volume also. So it will wash out the carbon dioxide and improve the oxygenation. The PIP I change in conventional ventilation. By independently choosing mean air pressure, I can probably keep a balance without altering PCO2. I can improve the oxygenation. That happens usual situation. But you can see it is not true always. So when you are changing mean air pressure in HFO, remember it recruits more and more units of alveoli. So there is a ventilation also improves and carbon dioxide wash out also happens. So it is not that I am just touching the mean air pressure. I am not influencing the carbon dioxide. It looks within a range, but with a higher map over distance of the lungs, it can influence the ventilation. So they are decoupled, they are separate, but in extreme of range, if you choose, they are again interrelated. So conventional ventilation, it is more frequently it happens. You can see so many arrows. It can PWP, mean air pressure can influence ventilation, rate can influence oxygenation. So many zigzag puzzles here. Here it will decouple, but remember with increasing ventilation, sometimes we can get a influence of, we try to influence oxygenation, but it influence ventilation also. And the TI, which usually influence the ventilation, with TI changing, as I spoke before, the previous HFO ventilations, they say 1:2. Current generation of ventilation saying 1:1. So when we are putting 1:1 TI-T ratio, it also improves oxygenation. It influences oxygenation. So this two-way the influence happens. We should remember these variations. Then coming to one parameter, probably I understand the mean air pressure FI2 we can choose safely. Now I will go to the amplitude. Amplitude time, the current recommendation says don't paralyze the baby to ventilate with HFO. Allow the intermittent spontaneous breathing. If baby is struggling or asynchrony, probably HFO may not work. But HFO to work properly, baby needs asynchrony, but spontaneous ventilation can be allowed. So you can see when we parallelized previously, few years back, how people accept little higher delta P. So when the amplitudinal delta P, this should start from the clavicle to below the umbilicus. It should be visible equal movement we should see. That's previously. But currently, probably people are accepting. In between, you can see here on the bottom video, there is spontaneous ventilation happening. Along with that, the wiggle factor, the chest movement, you can perceive it here. But same again, adequate chest movement or wiggle, how to say, when we are putting the delta P, we have to go bedside, making our eye horizontal to the chest. We should assess, we have to lower our eye to the chest level, and we should observe how wiggle is happening. The wiggle should happen from the clavicle to the below umbilicus. That's known as the adequate wiggle factor or vowel factor. That's the clinical. But how to choose with the number? You choose a number, and that should produce an adequate wiggle. Adequate wiggle or optimum wiggle is from the clavicle to the umbilicus. But how to choose with a number? So the number wise, few of the examples I'm giving here. So last box you can see, if the mean airway pressure, we are choosing 10. So 2 times of that, 20 delta P amplitude may be appropriate. Again, we have to see the chest wiggle to see, is it okay or not, clinical assessment. Or many times you will see the PIP. If you use the PIP 20 or PIP 18 or 16 in the conventional ventilation, if you are changing to the ventilator, plus 10, if 18 or 16 plus 10, if you can say 26, 28, you are right in your delta P amplitude. These are 2 things, if you can remember, perfectly fine. The twice of the mean airway pressure and PIP, whatever used in the conventional ventilation, plus 10 to 12. These are 2, any things you can choose initially, but you have to see the wiggle, it is producing adequate wiggle or not. That's the clinical parameter you have to observe. With that, probably 2 of the clues. One is values with a formula, knowing the previous setting in the conventional ventilator, and observing the baby bedside, we can know that is it adequate wiggle to the baby. And the wiggle why you are choosing, adequate ventilation should wash out the carbon dioxide. And within 30 to 45 minutes, this ventilation affects the blood gas. So as we discussed for the mean airway pressure, within 30 minutes to 1 hour, we should do X-ray. If we are putting the baby on HFO, by 30 minutes to 60 minutes, at least do a ABG. Otherwise, if hyperventilation, carbon dioxide was out, hypocarbia, again CNS injury, then you will lose the advantage of HFO here. So key is the monitoring, and within half an hour to 1 hour, at least bedside, you can monitor and you can do a ABG, which will give us the guidance. Okay, this delta P is adequate, optimum, or we can little wean further. Or if the PCO2 is still not clearing, if the higher PCO2 is there, still can we go a little bit of more delta P? Yes, you can increase. With a mark of 12, you have chosen 24 to 25, the delta P. You can go on up and little increase. If the PCO2 is 55, 60, 65, you can go a little up. How up we can go? The rule is the delta P whenever crossing thrice of mean airway pressure. If the mean airway pressure is 12, you are crossing delta P 36. Mean airway pressure is 15. You are crossing 45. Think once, because it can trap the air. Air trapping starts after this level. If the delta P is more than 3 times of mean airway pressure, air trapping happens in the lungs. So you won't get the advantage. If the disadvantage starts, air trapping and retention of carbon dioxide happens again. And a lot of injury to the lung starts after that. So if you're really increasing the delta P to get the ventilation more than 3 times a mark, revise the mean airway pressure, revise the TI, revise the frequency again once. Look, is there a block in the ET tube? Is the secretions blocking? Is there issue in the circuit? Clinical reassessment is important if you are crossing more than 3 times. That's the guidance. Given this is a formula, all the other, when you are choosing mean airway pressure delta P, the relation 3 times, and the mean airway pressure when you are choosing delta P, that rule applies to all other current generation of ventilator. But if you are using Drager baby law, remember this is a formula written in the book, the manual of Drager baby law. So for each mean airway pressure, the desired amplitude they have already given in the manual according to the formula which is quoted here. Beyond that, if you are putting the amplitude, practically it is not going to help the baby. So if you are increasing the amplitude to get the adequate wiggle, by that time you revise your mean area pressure. So if you are putting a 12 mean area pressure, but your amplitude is 100% you are choosing. Here it is not on CM. In the baby lung, it is 60%, 70%, 80%, 100% of the mean area pressure. So if you are 12 mean area pressure, amplitude 100%, probably beyond 85% is not going to help you. So if the carbon dioxide washout is not happening, adequate wiggle is not happening, then probably you have to choose your frequency wisely and you have to increase the mean area pressure as per the need. So if you drag a baby lung, that's the guideline, little different. And coming to the mean area pressure over, amplitude over, FIT over, how to choose the frequency. No fixed cookbook, no fixed formula. Depending on the disease, the frequencies are different. You two different X-rays I have put it here. You can see the first one is HMD. The right side one is a pulmonary interstitial emphysema with a lot of air leak. So how these both are preterm babies, 900 gram or 850 gram, but with the two different disease, the need of frequency will be different. They cannot be similar. So we have to understand first what disease we are ventilating. Depending on that, we can choose our frequency. So to understand that, the pathology, when the pathology is different, the lungs resonant frequency or the corner frequency is different. There is a formula. The corner frequency or resonant frequency is half pi R multiplied by C. R is resistance, C is compliance. You are conversant probably with R multiplied by C, knowing the time constant in the conventional ventilator. This is also similar formula, half pi multiplied by R multiplied by C. Depending on the resistance and compliance, the corner frequency or the resonant frequency of lungs is different. For that reason, when you know the disease, which disease is a low compliance disease or high resistance disease, HMD, chronic lung disease, meconium aspiration disease, depending on the disease process, we can choose our frequency. To make it simple, I am giving a guidance here. If you are ventilating a baby with a preterm HMD or a pulmonary interstitial emphysema, early phase, you choose your frequency 12 to 15. If a very small baby, less than 750 gram baby, I will suggest choose the frequency 15. You can come down to 12 or 10 later. Higher frequency, lesser carbon dioxide washout, less incidence of hypocarbia, you will get if you are choosing a higher frequency. But coming to if the baby term lung disease, meconium aspiration, congenital pneumonia, PPHN, term lung disease, 8 to 12 frequency is ideal. Start with the middle 10. Depending on the need, you can go to 12 or come down to 8. Meconium aspiration, very heterogeneous disease, bad lungs, imminent air leak possibility. Those bad lungs might require 6 to 9, 6 to 10 frequency also. These are some of the babies. Meconium aspiration, very bad lungs, PPHN, they might require also lower frequency. Or established pi, a 4 weeks age old baby, 6 weeks age old baby, chronic lung disease, pulmonary interstitial emphysema is well established, lower frequency might require sometimes. So these are the pattern of disease. Depending on that, you can choose. Coming to CDH, when CDH also, we don't choose a higher frequency, we choose a moderate term wave frequency 10 to 12. Depending on the need, carbon dioxide very high, sometimes we have to keep a little bit of lower frequency, carbon dioxide lower side, we can choose a higher frequency. And depending on some of the extreme conditions, two of the extreme examples I'm given here, 6.9 pH or 7.7 pH, very alkalotic or very acidic. Do you think just sitting with a number is going to help? No. These extreme conditions, when carbon dioxide is so high, 93 with 6.9 pH, I have to choose little higher delta P, I have to choose little lower frequency. So to wash out the carbon dioxide to a physiological range of 40-45, or when the carbon dioxide 17 in this example, I have to choose a higher frequency, lower delta P, so less ventilation. I have to allow the carbon dioxide to build to a normal level. So extreme conditions, be careful. Otherwise, in standard conditions, oxidation or carbon dioxide going to achieve those guidelines of delta P, 2x of MAP, mean area pressure, 2 cm above the conventional ventilation, frequency 8 to 10 depending on the different pathology, works well in majority of conditions. So coming to the TI, I already discussed, I'm not going to discuss here. The previous generation of ventilator machines, they say the I ratio 1:2, and present generation of all the modern ventilators pictures are there. They say the I ratio you choose from beginning 1:1, which helps for oxygenation with protecting the lungs further. Coming to end of these three parameters, I will last important clues or tips I will give it here. Current generation of ventilator with HFO, they have a volume guarantee. We in the previous session, we discussed volume guarantee in conventional ventilation. We liked volume guarantee or volume target in the conventional ventilation, but it protects the air leak, it decreases lung injury, it decreases chronic lung disease, it decreases the CNS injury, PVL, IVH. So we liked VG. So why not in HFO? Similar principle now, it is more popular now current age. All new generation machines having VG, we can choose directly volume guarantee. Without just choosing the frequency and delta P, here we can choose the volume guarantee of, like conventional ventilation, we are choosing 4 to 6 ml per kg. Here 1 to 1.5 to 2 ml per kg we can choose for the different disease process, and the alteration happens in auto alteration of delta P and frequency happens. We have to choose a mean air pressure, choose a FiO2 for oxygenation, choose a volume 1.5 to 2 ml per kg. The fluctuation to get that, the fluctuation of auto fluctuation of delta P and frequency happens. But here, whatever till now we discussed in HFO, when we are decreasing frequency, the tidal volume increases. We are increasing frequency, the tidal volume decreases. So tidal volume inversely proportional to the frequency in the HFO. But if you are adding HFO from VG, it is directly proportional. Remember, in different examples I have shown here, mean air pressure 24, 24, 24 with 100% effort in a Tom PPH and babies here. But the first example, frequency 6, second frequency 8, and third frequency 10. So in this, you can see it here. When we are choosing, then the VG, we are choosing different frequencies. The delta P alters a little bit, but the DCO2, which talks about tidal volume of the minute ventilation, with lower frequency, lower DCO2, higher frequency, higher DCO2, which is in the VG, little variation. By application bedside, you will learn it's better. Just this concept to remember, I am introducing you. Here, same thing. So whenever there is a frequency goes up, the DCO2 or minute ventilation goes up. And mean air pressure also rightly you have to choose in the VG. It is 1 to 1.5 ml when you are choosing. You have to choose a mean air pressure which recruits the lungs, and 6 to 8 rib spaces we are getting above the diaphragm. Here the typical, the article you want to go, the previously I documented here the article, the ADC archives article 2023. This is the guideline. These are they advised to choose in the VG different DCO2 or VG, how we can choose in different frequency. So when we are different frequency, we use the set tidal volume guidelines here given to achieve the targeted or desired minute ventilation, which is normally DCO2 reflected in the conventional ventilation, in the HFO ventilation. The range should be 40 ml per kg square per second. If a 1 kilo baby, that's different. 2 kilo baby, that's different. This table is a guidance published in archives. You can go and see. You can apply whenever you are applying HFO plus VG. So with this, I will close the HFO VG. Straight guideline now. What are the indications of HFO ventilation? HFO, when we are seeing the conventional ventilator, baby is not improving, poor oxygenation, oxygen induction is 15 to 20. Probably we can use a rescue HFO in conventional ventilation. And whenever we use nitric oxide works better HFO in comparison to conventional ventilation. These are the few things in general gross. But when there is a conventional ventilation already in use, remember these two values. If baby is less than 34 weeks, if we are crossing the mean air pressure more than 10, we can shift to HFO if you like HFO in your unit. If a late preterm or term baby, with the PIP we are using more than 24 or 25, or the mean air pressure is more than 12, probably we can rescue HFO we can use, because 24-25 PIP start injuring the lungs with higher tidal volume. So you can rescue with HFO, which can lower tidal volume, we can ventilate. And when you are using the ventilator set, how to set you understood. You can see that during the ventilation time, you see the oxygenation is low, SpO2 is low, below 90. You can increase FiO2, increase the MAP as I discussed, 1 or 2 cm more. If you got a higher O2, means SpO2 is more than 95 crossing, you first wean the FiO2 from 100% to 95, 95 to 90, till it reaches to 60. Once it reaches to 60, then try to wean the mean air pressure. If under ventilation, means carbon dioxide is high, hypercarbia, then increase amplitude fast. If it is not able to handle, then touch the frequency. If overventilation, you are overventilating, carbon dioxide is low, so immediately decrease the amplitude. If still it is not helping the baby, increase the frequency. This is way to start, initiate, and monitor further. And during whole process, remember that the vital parameters of the baby is important. You connected HFO, you left outside of the hospital or the bedside, you were not there. It's a very, very tricky situation for HFO ventilation. So as I spoke, whenever we are putting HFO, immediately what happens? If higher HFO, MAP, there is alteration in the vitals, tachycardia, hypertension, metabolic acids built up. So remember to monitor the baby clinically. Tidal volume, if we are HFO, we are without which also using, monitoring of tidal volume should happen in a 1.5 to 2 ml per kg. DCO2, which equivalent to minute ventilation in the conventional ventilation, should be 40 ml per kg or per square per second. That's the value. Different disease process will be different. Trend to be monitored. And ETCO2, TCO2 don't monitor, but throughout the ventilation, when we are seeing, you see that there's rapid PSO2. If there is rapid increase in PSO2 or fall in the DCO2, the minute ventilation, think there may be kink, block, or dope situation, displacement of tube, obstruction of tube is a possibility. Check the ET2 position, check the baby's wiggle factor. When there is sudden leak happens, you can see the ventilation, the mean airway pressure won't alter much. It will remain same because block is somewhere, maybe in the tube also. But the flow comes down suddenly. So when there is a sudden airway obstruction by the secretion or the kinking of the tube, this type of graphs happens. Be careful bedside to monitor. This is the final slide, the summary slides. I will say here, you can take snap and you can use later also. Our purpose of a ventilation by HFO is oxygenation and ventilation. When we are talking about like oxygenation, we set our ventilation to 60 to 100% to achieve oxygenation as per the need, and the mean airway pressure 2 cm above the conventional ventilation. And once stabilized, we try to decrease the FI2 first, then the MAP later. And if the ventilation target, we are with a different disease process, we understood how the frequency to keep. If a term baby, bigger baby, 10 frequency, smaller baby, 12 to 15, less than 1 kilo baby, 15 frequency to start with, come down later to 14, 13, 12, and 10. And the delta P to choose, 2 of the MAP already we decided, 2 cm above the conventional ventilation. If 10 in conventional ventilation, 12 in HFO, in the high volume strategy, twice the value of MAP is the amplitude we are setting. Depending on the carbon dioxide high, we have to adjust our delta P and frequency as discussed before. This is the summary slides. With that, I will give a few messages here. Despite there is no clear evidence one is better than other, many of the sick babies, small babies, PPHN babies, and air leak babies, it can be used as a rescue. Whenever PPHN with nitric, think about HFO with nitric rather than nitric using with conventional ventilation. And remember that optimum recruitment is the key. Hyperventilation, hyper expansion of the lungs is harmful. So 6 to 8 rib spaces above the diaphragm should be in the first 1 hour after the HFO in the X-ray. Amplitude is key to the carbon dioxide removal. So clinical bedside monitoring of the wiggle factor of the baby from the clavicle to the umbilicus should be there throughout. And chest X-ray within 1 hour, ABG within half an hour to 1 hour we have to do to monitor. And frequently don't remove the circuit for the suction. Other thing is de-recruit the lungs, more damaging. And when you are monitoring tidal volume and DCO2, monitoring the ventilator chart, all the current generation of ventilator will have that. With that, I will conclude. The machine is not panacea for all disease. Knowing the machine well, knowing the ventilator setting well, probably will influence the outcome to get the best outcome. With that, I'm closing the session. Now we'll start taking questions, and I welcome or Surinder sir. He has joined. If he will be there with the question answer session, it will helpful to us. So few of the questions I will take now. You don't have the option directly to ask questions here, but you can put on whatever the discussion we did, any doubt to clarify, you can still put the questions and I will try to answer it. I got few of the questions, so I'm taking it now. So the first question we got from anonymous attendee. Sir, the MAP is always 2 cm above the conventional ventilation, irrespective of the I ratio. So the MAP, when we spoke about the mean airway pressure, I talked about two different concepts: the recruitable lung or the recruitment required, like preterm RDS or term baby congenital pneumonia with derecruited lungs. We require 2 cm more the conventional ventilation, irrespective of I ratio. The standard I ratio current generation is 1:1. You can choose 1:2 also if you're using sensor medics or other old generation HFO ventilators. But the mean airway pressure, if 10 in the conventional ventilation, you can choose 12. But specific conditions, as I highlighted, when we don't want high volume ventilation. Hello, sir. Just welcome you to the session. Today I'm
Hi.
alone. Just
So I saw, I saw you alone. So
so
good. There was a next going on, Learn with Legion going on the other part also. So I was there also, and I joined and I saw the summary slides and the slides before. And as you rightly said, obviously we usually do this. And for these students who are here, who are about to go for exam as well. So sometimes when the patient is on HFO in the during the exam times, so some students have actually told us about why HFO was used in that, and then they have told us about the OI concept, OSI concept, why this was used, why what was the indication of using HFO, which you just told in the last of your slides also. That was done. And in a only thing I wanted to add, Dr. Nalini, is in patients with ear leak, probably then we'll go 2 centimeter lesser than the map which was earlier given. So, like in somebody who has developed a pneumothorax or pulmonary interstitial emphysema kind of situation, there probably we would, I hope, we go 2 or 2 centimeter lesser than the map which was already in the conventional ventilation.
So that we discussed in the first initial 3-4 slides. We said that is optimal lung volume. Optimal lung volume, same map, you can keep whatever in conventional ventilation. No need to go up. There's a clear guidance. One is high volume optimum strategy. One is optimum lung volume. Sorry, whatever example you are giving now, air leak or CDH baby or baby already having a pie changes. In those are the cases we should not target a higher map. We should target whatever in existing in conventional. Let's continue that and check with X-ray if hyperventilation, come down with the map as early as possible. That's the guidance. So that's good feedback. So please, next question came. Please explain about recruitment maneuver and extubation readiness of HFO. Recruitment maneuver is popular in ARDS and pediatric population. In neonates, when we are using to try to use the low tidal volume optimum recruitment, we don't recruit the lungs fully, so which can injure the lungs more. So it's not standard, but a few of the units, special units, they used. But coming to the extubation readiness, I will say whenever your map is decreasing below 10, it came to 8 maps. Standard preterm baby is 8, term baby is 10. You are getting a good airway, the primary pathology is resolving, and mean airway pressure is 8 or 10. If your F5 needs close to 40%, now we can switch over to either conventional ventilator or the baby is ready, you can extubate to NIV or CPAP also. Both the approaches are acceptable. So you can, from HFO, no need to every time go to conventional ventilator. I'm already came down to 40% F2, came down to mean airway pressure 8. I can go to NIV or CPAP, or I can go to conventional ventilator. If the disease process is prolonged, if a very small baby, 25-weeker, 24-weeker baby, I'm still not ready, I can continue ventilation. But a Tom baby, which the pathology is the result, why to continue ventilation? Take out to CPAP or the NIV. That's where the extubation readiness.
And do you do extubation? Do you go down to nasal HFOV?
HFO, nasal HFOV, we have used in some of the cases when we extubated the baby, and now we are seeing that, okay, this baby is going to fail in extubation, re-intubation required. We rescued the babies with nasal HFO, particularly when we saw the carbon dioxide retention is high, oxygen requirement is 42%, carbon dioxide is 87%. Just use not intubation. But primary mode, we never used nasal HFO. Our experience primary, but extubation
Sure,
after.
sure. Extubation, yeah. So this is just an idea to the students that some people are actually using nasal HFOV as well for primary ventilation as a primary mode when you're using HFOV, and certainly for extubation people have used it. So I think the studies are still going on, and there more data is about to come about nasal high frequency oscillation ventilation usefulness. But certainly there is a room for it, and I think in future there is a, when you are going for non-invasive ventilation, and there is a place for non-invasive HFE, high frequency oscillation ventilation as well.
Absolutely. Absolutely agree. So HFO, but I will say the student mask or the Rams cannula both works well with the nasal HFO. If you got a machine and both the interface works well, you can use it. I have not seen with the Hudson prong. My experience with the mask, nasal mask, midline nasal mask, in the Rams cannula. Both we have used. Small babies mask we have used. More than 1.5 kilo or 2 kilo babies, we have used Rams cannula. In 1 kilo baby, we have used nasal mask. Both the time, it
So,
works well, though it is very common.
so Dr.
So,
Dr. Nalin, so I was just I was in another seminar. Today, 2 or 3 seminars, webinars were going on, and they're in the adult ARDS. And their HFO is like, we are so fortunate in neurology that HFOV is working for us. For other people in adult ventilation or in bigger children pediatric ventilation, HFOV has not been found to be as good as any other ventilation. So luckily for us, for our CDH babies, for our PPHN babies, for babies with severe pneumonia, RDS, HFOV has been proven to be a good therapy in all, and that has certainly helped us. The only problem with the residents in my hospital and somewhere I see is they don't monitor OI, they don't monitor OSI, and do not go for HOV when they need to go. And then when the baby is almost collapsed and going into very severe hypoxic respiratory failure, and then you are trying to put the baby on HOV, and then say HOV has failed. You should choose the right time to put the baby on high frequency oscillation, and then the result will be certainly quite beneficial.
absolutely. Absolutely. Right time, choosing a medication at right time is the most effective. So for that reason, the common guidance is given. If the baby more than 20 PIP or mean air pressure more than 10, you are sitting at higher FI2 in a small baby, or 12 MAP or 24, 25 PIP, you are not struggling, not achieving oxygenation. Think once. Because if you're using 30 PIP, injuring the lungs badly, and rate of 60, rate of minor ventilation very, very high, FI2 sitting at 100 for long period, oxidant injury, then I will change to HFO. Is it going to helpful? So right question you got suggested, sir. So the right time. So when we are crossing a limit, we have to think, because primary
So,
HFO mode majority they don't use. It's a rescue
so
only.
and I,
So yeah,
So I
please.
certainly want the students to actually monitor OSI, oxygen saturation index, as a routine parameter with every hour when you are going and touching the patient. You're looking at the saturation and you're looking at the things. So oxygenation saturation index is something which you can easily monitor. You don't have to do an ABG for this. And anywhere it is going near 6,666 or something like that, you know your OSIs are in the higher 6 and 7. Probably this is the time when the baby should be going for some higher. Your conventional ventilation is failing because you are already on the higher asset PIPs and all that. So your OSI tells you the correct thing. OSI. So please go with the OSI.
So another interesting question came, which is very relevant to the clinical bedside care provider. How frequently to monitor chest X-ray and ABG? So as we discussed the guideline talks, 30 minutes to 60 minutes we have to do X-ray and ABG. How frequently? The baby is stable like conventional ventilation. No need to do it very frequently. If you are changing some parameters, then higher parameters probably X-ray required. Otherwise, weaning for the X-ray may not required at all. But ABGs, as per the baby's sickness, it might require twice a day or might require 3 times a day. But as per disease process, as per the sickness, just HFO you're weaning and improving baby might not require very frequently, but still I will suggest a HFO baby. The wash out of carbon dioxide danger is always there. So monitoring the DCO2 in the monitor, monitoring the DCO2, monitoring tidal volume, many times helps. Monitoring the saturation, and the SAR is suggesting monitoring OSI, ABG you are doing, monitoring OI, so all will help. And ABG is at least thrice a day or twice a day we should do if the baby is on HFO. But X-ray agent when required only, not a mandatory. Once the diagnostic recruitment part is over, we don't think, unless the baby deteriorates, we don't think routinely X-ray required for the baby. And nowadays, I will request
So
the
for
registers, lung ultrasound. Lung ultrasound, if you can use, you can detect your hyperinflation, detect your atelectasis, and can detect air leak also. So you can use it rather than putting with the X-ray. Baby.
that's great. And don't just give an idea of a routine ABG and to 6 hourly, 8 hourly, some kind of ABGs that kind of concept is long gone.
That's right. So another question is that the Ram's cannula, is there a change in amplitude? Yes, you are right actually. Any of the Ram's cannula or mask, there is a peri interface leak is expected. When there is a leak, definitely amplitude will come down a little. But we have to clinically, we have to adjust it. We increase the amplitude a little more so that the chest wiggle we are getting. Unless the adequate chest wiggle is there, is nothing else the CPAP only. Remember, whatever setting you are putting, if you are putting FiO2 or MAP or the wiggle and the frequency, if chest wiggle is not there, this is not delivering at the alveolar level. Just a MAP is going, but how it will reach to the alveolar level unless the adequate wiggle is there. So CPAP, which is a mean air pressure, plus wiggle adequately is your effective HFO. Unless the wiggle factor is adequate, the HFO is not delivering. That's the way to say. So there is a leak or something, you have to reassess your wiggle repeatedly, bedside, which can be done bedside without any investigation. So we got probably majority of the questions we covered. See any other thing today, then we can probably close the session today. Somebody asked a TCO2. Is it a TCO2 is actually majority of conventional ventilator in bigger babies, they use ETCO2. By ET sensor, they can put an adapter and can monitor the ETCO2. But in the conventional ventilation is a tidal volume ventilation, so it's possible. This is below tidal volume. So ETCO2, we cannot monitor carbon dioxide in HFO ventilator. So the standard way of monitoring CO2 without doing ABG is transcutaneous carbon dioxide monitor. Machines are available in India. It's available. Only the trick situation is the probe, the sensor is a big one. For the small babies, it is little trouble to keep in chest and arm. But for the bigger babies, tom babies, you can monitor constant TCO2. So there is a variation in the amplitude, variation in the wiggle factor. The TCO2 carbon dioxide part constantly you can monitor. That's the way to monitor. That's a TCO2. So we covered probably, I hopefully, all the questions. Inline suction is a good question. 2 kilo above. Now the current generation of inline suctions are available in India. If you're ventilating a baby more than 2 kilo, no need to repeatedly detach and do the suction. You put an inline suction without de-recruitment, without discontinuation circuit. You can do the inline suction. But below 2 kilo, it is a little tricky because it may block your ET2, block the dead space may introduce more. So a little tricky in less than 2 kilo. Above 2 kilo, now you can achieve inline suctions happily. Is it possible to give VZ in nasal HFO? Tricky question. When there is a leak, there is VZ, ensuring VZ is maybe tricky, but you can monitor the with leak also how much tidal volume is delivering. You can do with the HFO, but HFO with VZ, I am not much experienced, and I don't think much literature available on when there is already existing leak. So that way we are probably completing all the questions. So thank you all of you. Dr. Surinder sir, thank you for joining and giving inputs. You can speak few words to the student, and thanking all the students for till now. Say all the students are still active.
Thank you, Dr. Nalini. And I think thanks to all the students because they are getting ready for their exam. I'm so excited. The dates have come. Students are now ready to go for their exam. And we hope to see them fine and let everybody pass with flying colors. All the best.
Okay. Thank you all. Thank you all. We'll go. This is the last session of respiratory module. With this, we are closing the respiratory module. Next time, it will start with the CNS module. The CNS case presentation, 2 or 3 case presentation, and 2 or 3 important chapters we will cover in the next few weeks of session. So this respiratory CNS like that one module. Thank you all. Good night. We'll meet again next.
Thank you all. Thank you. Good night. Good night.